So this is the first in a series of virtual COVID town halls that we're planning on hosting, which are intended to inform our community about the current state of where we are in managing the COVID-19 virus. And this really couldn't come at a better time. So before I go any further, I know are all socialized to hear about numbers when we start talking COVID. So as of yesterday, the Maine CDC has reported 3,992 total cases of COVID-19 in Maine and 36 in Hancock County. Now, remember, these numbers represent the number of positive tests that have been identified, people with positive COVID, since the beginning of our testing process. And the 36 in Hancock County is 36 people who live in Hancock County that have reported positive tests. Now, the reason this is such a good time for us to have this conversation was after several months without any positive test results, our hospital, where we run a lot of tests, has recently received confirmation of 3 new cases. And we've also received an increasing number of calls from visitors who have received some positive test results after their arrival. So one of the things we want to point out is that visitors who test out of state that receive positive results after traveling to Maine are not captured in the data at all. And people who do test here in Maine but have an out-of-state address, they are counted in Maine's total, but not necessarily in the county where they're, but not in any particular county. So they could have tested positive, have a Philadelphia address, but be in Hancock County when they have their test and get their results. They are not included as a Hancock County resident. So that has created a lot of confusion that we've worked hard to try to just help people understand how that data works. But we also, having visitors who arrive from out of state without any results in hand and find that they're positive, that creates a particularly challenging situation for us. But to mitigate this, I'm very pleased to report that we met with Commissioner Jean Lambro and Dr. Nirav Shah yesterday, and we are establishing a new pilot contract tracing partnership to address this issue. So this partnership will grant us public health jurisdiction to use the SARA alert system in a way that hasn't been done before to log and trace these visitors. So our community has done a really, really spectacular job at keeping COVID-19 precautions in place. And because of this, the incidence of COVID-19 in our community has remained low. Because of this partnership, we have a greater opportunity to make sure that the public health precautions that we have available to us as Maine residents through the state CDC is also available, becomes available to our visitors who have to rely on a state health department in their home state. So today, you'll be hearing from 2 of our practitioners on the front lines of our coronavirus prevention efforts at MDI Hospital, Kate Worcester and J.R. Krevans, Jr. Kate Worcester is a certified physician assistant who has been our primary COVID testing practitioner and has taken a lead role in counseling and providing contact tracing assistance to residents and visitors. And Dr. J.R. Krevans, Jr. is chair of infection prevention at MDI Hospital and has been a guiding force of our COVID-19 preparedness response. He has an extensive background in public health, in emergency preparedness, and in the management of infectious disease. So after Kate and JR speak. There'll be a QA session at the end of the meeting. If you have a question, please use the chat feature at the bottom of the Zoom screen. A moderator will be monitoring the chat box for questions and will answer them if time permits. We will stop after our first speaker, and if there are some pertinent questions that can be answered on a timely basis, we will we'll interject those. But again, I remind everybody, we will try to answer questions at the end, and any questions that do not get answered on the telecast will be answered directly with the people asking the questions. So now, please join me in welcoming Kate Worcester.
Thank you. Ready? Coronavirus disease 2019 is a pandemic influencing the first half of the year 2020. The virus has rapidly spread to many countries. Presently in our community, there are confirmed cases of COVID-19. Many of these cases are persons who have been tested to travel to this area and receive their test results after arriving. Many of these persons do not have any symptoms of COVID-19. There is no community transmission at this time. The following talk is on basic facts about COVID-19, what symptoms to monitor for, how to be tested, and how to reduce workplace transmission of the virus. I'm also going to highlight what to do when you're tested and what to do if you're found positive for COVID-19. December 31st in 2019, hospitals in China reported a cluster of pneumonia cases of unclear etiology. With the use of real-time reverse transcription polymerase chain reaction, or RT-PCR, this was identified as a novel coronavirus labeled as severe acute respiratory syndrome coronavirus 2, later also known as coronavirus disease 2019, or as we know, COVID-19. Coronavirus is not a new virus. This is a virus that has gone from animals now to humans. Compared to SARS, COVID-19 uses the same mechanism of entering host cells, but at slower speeds. However, COVID-19 accumulates more in the system compared to SARS. This explains why COVID-19 has a longer incubation period and is more contagious, while SARS presents with more symptoms and disease severity. The spread of COVID-19, unfortunately, is rapid, and the transmission is from close contact, airborne, and droplet. About 44% of the transmission is estimated to occur before symptoms arise, or the pre-symptomatic stage. About 18% of cases remain asymptomatic. Close contact is defined as within less than 6 feet for greater than 15 minutes, regardless of whether you're wearing a mask or a facial covering, unless it is fitted as an N95 mask or other personal protective equipment. Symptoms tend to resolve after 10 days. In 90% of patients, their symptoms resolve after about 10 days. Severe cases or hospitalized patients can continue shedding for up to 25 days after the initial symptoms will arise. Severe cases also have 60 times more viral load than our mild cases. People are thought to be most contagious when they are most symptomatic, otherwise experiencing fever, cough, and/or shortness of breath, and/or pre-symptomatic. However, there is transmission from some asymptomatic individuals. Therefore, maintain safe social distancing is always enforced, mask wearing, and hand hygiene at all times. Here is a picture I did here with showing our incubation period and your symptoms, where at the bottom you're showing your latent period and your infectious period according to a timetable. So you can see that during the incubation period and your onset of symptoms, you're actually becoming infectious while you're incubating and not exhibiting your symptoms. Your resolution of symptoms, you're still infectious during that period of time when you're having your resolution of symptoms. Go ahead. What to know about COVID-19? Coronavirus or COVID-19 is an illness caused by a virus that is spread from person to person. Most patients will present with respiratory type symptoms and a fever. COVID-19 symptoms can range from mild or no symptoms to severe illness. Severe illness tends to happen in patients over the age of 65 who have underlying illness, including hypertension, coronary artery disease, and diabetes mellitus. About 41.8% of the patients we see would develop acute respiratory distress syndrome, otherwise known as ARDS. This condition presents with worsening shortness of breath, increased work of breathing, and hypoxia, or lack of oxygen. This typically presents in the first 5 days of illness. About 81% of cases are mild, do not require hospitalization, 14% are severe, and 5% are critical. Mortality increases with the severity of the disease. Severe cases have an unpredictable prognosis solely based on their clinical presentation. What the medical provider wants you to know about COVID-19. Typical symptoms of COVID-19 are going to be fever, cough, shortness of breath, sore throat, loss of taste or smell, body aches, diarrhea. Some patients do not have symptoms. They are referred to as asymptomatic patients. The time of onset of symptoms, as few as 2 days or as long as 14 days after the exposure. Most patients exhibit symptoms in the first 5 days after their exposure. How COVID-19 is spread. The virus is thought to spread mainly from person to person, including between people who are in close contact with one another, which is thought to be about 6 feet, through respiratory droplets when it's in close contact, less than 6 feet, higher risk when you're in closer contact for greater than 15 minutes. Contact with an infected surface that a person then touches their own mouth, nose, or possibly their eyes. Testing. If tested for COVID-19, the current test format is to do PCR testing. This is done with either a nasopharyngeal swab, oropharyngeal, or an anterior nair swab. This form of testing will detect approximately 90% of cases. In patients with symptoms, this type of test is more accurate than those without symptoms. So those patients who actually have symptoms, we're going to have a higher sensitivity than those that are asymptomatic. Most people will not be aware when they are exposed to COVID-19. If you develop any of the symptoms of COVID-19, contact your primary care provider at MDI Hospital or the COVID hotline, which I've placed on the slide. If you become aware you were exposed to someone who's COVID-19 positive by a confirmed case, a patient should immediately self-isolate and contact the COVID-19 tent. My workplace recommendations for you. If an employee contacts the employer with any of the symptoms I've placed before of COVID-19, they should be instructed to contact their primary care provider, MDI Hospital's hotline, or the COVID tent. Employee is instructed to not return to work. The primary care or the COVID tent provider will determine if testing is indicated. Presently, each employer does have different policies in place. We certainly follow those policies in regards to when the employee can return to work. From a medical provider's standpoint, if testing is felt to be indicated, the employee will remain in isolation or quarantine until the results are complete and symptoms have resolved. The employee then can return to work. These are my current recommendations I give to employers. I encourage employers to cohort their employees into groups of less than 10 in the workplace. This will limit the workplace transmission, and if an employee is found to be positive, contact tracing can be done more efficiently. All employees should wear a mask when working in a distance of less than 6 feet of each other. Encourage frequent hand washing, ideally sanitizing each time they contact a new patron. Have a single point of entry. Do daily checklists of symptom monitoring before employees enter your building. If an employee has any of the symptoms, they are to return to home, self-monitor, and contact their primary care provider, the hotline, or the tent itself. If you're tested for COVID-19, you're to return to home. You're going to maintain a strict home quarantine as defined below. You're to be told not to leave your home, no distributing of goods, foods, or supplies. Do not go to the grocery store. It is recommended that no one in the home is to leave. If family members have to leave the home, avoid unnecessary contact with persons outside the home, wear a mask in social places, wash your hands before leaving the home, and sanitize just before shopping. If you're unable to isolate in the home, please do so. If you're able, to isolate in the home, please do so. Use a separate bathroom when possible. Everyone in the home should practice frequent hand washing. Avoid touching your hands and your face. Testing results. The time to receive your COVID-19 test results is going to be variable according to how many tests are actually sent and which labs are receiving them. Most tests right now are returned in 2 to 4 days. Until test results are complete, you are to assume your test may be positive. Maintain strict home quarantine versus isolation, as highlighted above. MDI Hospital does have a rapid cepheid test, but this is reserved for emergent hospitalized patients, emergent surgical patients, and frontline medical providers that must return to work in the next workday. The test cartridges are limited. Presently, it is unknown when this supply will be replenished. Therefore, this form of testing is being conserved. You will be contacted by a medical provider when your test is complete. If your test is negative, you can return to social distancing while continuing to self-monitor for any symptoms of COVID-19. If your test is positive, you are to remain in a strict home isolation. and a minimum, this will be 10 days. You will be contacted by a medical provider who will perform the test with specific instruction as to when your isolation can be lifted, as determined by a case-to-case basis. Protect yourself and others. There is currently no vaccine to protect against COVID-19. The best way to protect yourself is to avoid being exposed to the virus that causes this virus. It is to stay home as much as possible and avoid close contact with others. Close contact is defined as less than 6 feet. You're at an increased risk if you are less than 6 feet for greater than 15 minutes. Wear a cloth face covering that covers your nose and mouth in public settings. Clean and disinfect frequently, touch surfaces. Wash your hands often with soap and water for at least 20 seconds, or use an alcohol-based hand sanitizer that contains at least 60% alcohol. If you contact a confirmed COVID-19 positive person, you may be tested for COVID-19 as determined by the medical provider, typically in the COVID tent. Approximately 30% of contacts will be asymptomatic. Approximately 10% of the contacts will become COVID cases. If found to be positive, you'll be instructed to maintain a 14-day period of isolation. You will continue to do self-monitoring during this 14-day period. You will be released from isolation when likely non-contagious, 10 days, and improved symptoms for 3 consecutive days and without fever. Brief word on the super spreader, which was a question. Definition. The word is a generic term for an unusually contagious individual who has been infected with this disease. In the context of the coronavirus, scientists haven't narrowed down how many infections someone needs to cause to qualify as a super spreader. But generally speaking, it far exceeds the 2 or 3 individuals researchers initially estimated that the average infected person will infect. What makes someone a super spreader? We don't know yet what it is about the biology of some people that causes them to be super spreaders. It might have something to do with the increased viral load and shedding more virus than is normal, but we still don't know what would trigger this, let alone how to identify that through practical means. The most common presentation for the super spreader would be a mildly symptomatic person who continues to attend social gatherings without the use of a mask. This is more likely to occur in a densely populated area with poor mask compliance. These are my clinical caveats. COVID-19 is in our community. This will start to spread rapidly unless we as a community work together to reduce the transmission. The use of a mask should be essential. Presently, social distancing must be maintained to reduce transmission. I encourage employers to cohort their employees into groups of less than 10 to reduce the workplace transmission. If a patient has a negative test result and their symptoms have resolved, an employee can return to work. Presently at MDI Hospital, we have adequate supplies to test symptomatic individuals and those known with positive contact with a COVID-19 case. This may change as our numbers increase. Universal access to testing is essential to identify, track, and control COVID-19.
So we do have a few questions that have come through. One of the first of which was, is there actually community transmission on MDI?
No, there is not at this time.
There is not, okay. And then another question was, what is being done at present to prevent the subjects from out of state from transmitting the virus to others in our community? Have they been mandated to quarantine, and how is this being enforced?
So in the official state mandate, of course, is if you've been tested outside the state and you're waiting for your test result, you are expected to be isolated, be quarantined until your test result comes back. And if people are following the state rules, they are in a residence, if they're renting a place or if they've come to their own summer home, they are on their property there, and they are not interacting with people outside their own household. Some people are no doubt not following that. And that's why, as I think most people listening to this are aware, we as a community, the business community, all the towns have been involved, and the hospital. And I know Ellsworth has a very similar type program to try and get the best possible compliance with masking, both by patrons and by staff in restaurants. And also I know in Bar Harbor, I don't know about in Ellsworth, the setting up of outdoor service at restaurants so that people who do decide to go out for a meal don't have to go into a place. Ideally, they should eat at home. And the availability of takeout. So those are all ways that we as a community protect ourselves from people who are either unable or unwilling to follow the rules. There is no legal enforcement being done by the state at this time.
And then the last question that I received was, MDI Hospital sent out a statement that 35 non-residents have reported a positive COVID case. But in yesterday's main CDC update, Dr. Shaw said that it was about 5 people. Are you both talking about the same thing, and where does the discrepancy come
Can I answer
from?
that? You want to answer?
Yeah, I'll answer that. So the 35 number that's been bantered around is actually a cumulative number since we started keeping track of the calls that we receive. And it includes not just people who called to tell us that they have recorded positive results, but also their close contacts of theirs. So that was an estimate. It was never intended to reflect a current status of what's in our community. In our discussions with Dr. Shaw and Commissioner Lambrew yesterday, we discussed the fact that we've had a sudden, I'll call it a rash, and of course we're a small community, so small numbers constitute a rash sometimes. Within the past week and a half, sorry, it's in the mask I usually wear. Within the last week and a half, we had about a half dozen people, I think 5 in the last week, maybe 7 in the last week and a half, of folks that have called to tell us that they had received a positive result since they arrived in Maine. And it's that acceleration of these reports, which again is not totally unexpected. This is what we were concerned would happen as the summer progresses. And again, I think the exciting thing for me is that I think our community and the state have done a great job of positioning ourselves so that we can work to manage this situation.
The positive cases as well, they were family members that were the contacts only, and they were maintaining quarantine within their home when they found the results.
Okay. And then there was another question I thought was good. The travel community has suggested that during a 14-day quarantine, you can hike, bike, etc. That seems a bit contradictory. What do you think?
So I could, why don't I answer that, remind me to answer that when I'm done talking, because that's a perfect time for me to start talking.
Okay, go ahead.
Okay, so I'm J.R. Krevans. I'm a physician here at the hospital. Before I was a physician, I studied physics at an undergraduate level, and all that stuff is coming back in a big way. In fact, about a third of the reading that I've been doing lately is really physics and engineering based stuff. And so I'm going to be talking about the same things as Kate was, but in a little more depth about a few of the topics, so people can really understand when we think about transmission and about how to prevent transmission. I'm initially going to talk without slides, just because I'm more used to that. And then we'll switch into slides when we start talking about vaccines at the end. So people have heard lots about the transmission of this virus. It's incredibly contagious, far more contagious than flu, far more contagious than SARS, not as contagious as measles. So in fact, it's so contagious that it's been somewhat hard to study how it has spread. And so it probably spreads by multiple mechanisms. The first one I'll talk about is spreading on surfaces. Based upon both the physics and physiology of the virus itself and the increasing epidemiologic data, this is almost certainly the least important. The way the virus enters your cells is it has to attach to a mucous membrane, the eye, the lining of the nose, the lining of the throat or lungs. And it has to be there in sufficient quantity. A small number of virus particles won't succeed in infecting you. So if it's on this table, it has to get from the table to my hand, from my hand into my eye with enough viruses at once to infect me. It turns out that's not that common. And just basic good sanitation is what's really necessary, along with good hand washing. And that's not the biggest place we need to be putting a lot of our efforts. And then there's these two methods of transmission, which we separate officially in hospitals because we have to. But they're really a spectrum, not two different things. There's something called droplet transmission and airborne transmission. And these are commonly confused when people talk about them, but it's really an artificial distinction because one gradually becomes the other. Droplets basically are large particles. They literally impact us, or we breathe them in as a single large particle. When someone coughs on you and you feel it. But these are large droplets, and like any other drop, like a drop of rain, they will fall to the ground. And almost all of them will fall to the ground within 3 feet and way over 90% by 6 feet from the person who excreted them in most conditions. So unless you're directly hit by these, they fall to the ground. But then smaller droplets, and sometimes small droplets are produced when somebody coughs or sneezes. Some of the droplets they produce are small. Or a medium-sized droplet, if it doesn't fall to the ground really rapidly, part of it will evaporate, especially in dry air. And when it evaporates, then you're left with a little tiny residual called a droplet nuclei, which contains concentrated viruses. And now it's light enough, a mist, not a raindrop, that it will float in the air for a while. And those can be breathed deep into the lungs. So that's droplet transmission, big things like raindrops, or even small raindrops that fall, and particles that are light enough that they float around. The reason that matters is the protection against them is a little bit different. But when you actually get to the clinical studies, not as different as people make it out to be. So droplet transmission, being directly impacted. And a simple mask and perhaps a face shield if you're in a high-risk situation is certainly enough to protect you very well against almost all droplet transmission. A simple mask like I'm wearing right now allows air to flow through it. It's got very small holes. It would certainly stop a droplet. A tiny piece of aerosol could go around it. And that's what's called airborne transmission. And that's actually inhaling a floating particle. Particles too small to see, too small to feel into your lungs. To get complete protection, you need a fitted respirator, which is either what they call an N95 mask or a PAPR hood. And that will give you essentially complete protection from it if it's airborne. But also, interestingly, so will good ventilation. If you're in an open area where things are rapidly blowing away and getting diluted, that will also improve the situation enormously. And the important thing to recognize is something called the inoculum effect, which is a lot of...
Materials management to the loading dock, please. Materials management to the loading dock.
Actually, that's a great interruption. That was materials management, heard page. One of our big issues is getting supplies in nowadays. So we're always glad to be interrupted to hear that we've got more supplies coming in. So the inoculum effect is something probably some of you have read about, and it's fancy words, and it's a fancy way of saying it takes a lot of germs of this germ to cause an illness. While this germ is very contagious in the sense that it's good at spreading, it's not, it does take an inhalation of a fair amount. It's more like being attacked by a cloud of mosquitoes than a German Shepherd. You don't have to, you're not going to get sucked all the blood out by one mosquito. And if you only inhale a few germs or get a few germs in your eye, it generally doesn't cause illness, or if it does cause illness, it's very mild. Because of this in order to keep most of us protected most of the time, I mean, the world is not perfect. We don't have to eliminate every germ. We really need to get the numbers way down. And I'm going to throw out some numbers. And these are the numbers from about 4 weeks ago. There's been some refinement up and down in some of them and argument since, but they're pretty much the same. Yeah, let's pop this up. So a 6-foot distance, go back a couple slides, sorry. Back 2 slides. No,
Oh,
back,
sorry.
sorry.
Or the-
Back good, yes. So if you look at the chance of getting the infected, whether it's passing someone in a store because you're both looking for the same brand of noodles for a minute, or whether it's sitting in a conference room for an hour with your boss, talking to a bunch of interested people on the video conference. By being 6 feet away from Art right now, if he was contagious, I am about 5 times less than if we were sitting right next to each other. But he's wearing a mask. That mask cuts his ability to make me sick by about a factor of 6. I'm wearing a mask. That protects me by about a factor of 6. And these actually turned out to be multiplicative. So this gets really safe really fast if everybody follows the rules. If Art was contagious right now, and I was sitting next to him, as Kate said, the odds are probably about 40% that I would be infected by the end of this hour. Almost 50-50. By being 6 feet away and both of us wearing masks, even if he's infectious, the chance that I am going to be infected is 180, about 1 in 500. And even sitting together, talking loudly for an hour. I mean, it's because we have the multiple layers of protection. Face shields, which we'll mention, they protect the wearer by a factor of about 3. There has been a bunch of back and forth about how much they protect other people from you. I just saw some nice studies out of an aeronautical engineer doing high-speed laser photography in his basement. Not kidding. It actually was published in a good journal because it was a great study, but people have to work from home. And probably face shields are significantly less effective at keeping germs in. And I want to mention the key importance of ventilation. When you're outdoors, the risk is dramatically less for 3 reasons. One reason is that there's just lots more air to carry the droplets away. The second is a simple social one. It's much easier to stay 6 feet from people outside in general. Corner of Cottage in Maine, not so much, but most places, it's pretty easy to stay 6 feet from somebody most of the time, except maybe 2 or 3 seconds passing on a trail. And the third reason is an interesting one. Viruses are a very tiny set, there's a saying that the reason it's so hard to kill a virus is it's not alive, which is actually true. Viruses are not living creatures. They're a set of instructions that tell your body how to make more viruses. And if those instructions are basically naked instructions floating around, it's like having a sheet of tissue paper with lettering on it, not without a cover on it, a book cover. So ultraviolet light is really good at messing up those instructions and making them unreadable, which you don't want. You want the virus to not be readable. So this gets back to the question you asked, which I've actually heard 2 different people from the state at the same presentation give slightly different answers to. The legal rule, which is a very good rule, is to stay on your own property, or if you're renting, stay there and not go out at all. That's the law. there is a reality that if you are walking along, and I think the phrase, I think that like the thing of the day, Dr. Shaw was on the phone, a country road or something, like if you're renting in Soamesville and you're on one of those old logging roads out of Soamesville, you can keep a 6-foot distance from other people. That people talk about doing that. It gets to be a gray area very fast. Carriage roads, yeah, they can get busy, but they're wide. Gorham Mountain Trail on a sunny Saturday afternoon, good luck with that. And so I would say that the onus is on the person. They have to not create the circumstance where other people cannot maintain safety. It's one thing to, go to the end of your driveway and pick up somebody delivering takeout, to go downtown to downtown Bar Harbor and wait in the takeout line, is not maintaining social distance. So we talk about risk. Each contact is a risk. If there's more people around, more chance that one of the people you're with is infected. If you are the one who is infectious, if you're around more people, more chance you're going to infect someone else. The more time you spend in the infectious environment, if you are, in a store for 10 minutes, picking up some hardware parts, is different than spending 3 hours with the same number of people in a meeting environment, say. Some activities are produce lots more droplets. Coughing and sneezing, obviously, if someone's actively sick. Interestingly, singing, dancing, exercising, dramatically increased numbers of droplets, even if people are not coughing or sneezing while they're doing these things, or shouting also. So Kate talked about super spreading people, which occur. Something that interests me more is, and it's a huge issue for communities, more than super spreading people, are super spreader events, which you periodically read about them. The most recent one was the children's camp in one of the southern states, YMCA camp. They were way over 200 positives, and a lot of the kids didn't get tested because they got a bunch of kids together. They did YMCA camp things, complete with cheerleading. Let's stand on top of each other's shoulders while shouting. Singing crowds, bars, exercise classes. These are events where you can suddenly infect very large numbers of people. Funerals, weddings, and those type of events, because they put together all the things you don't want. Large numbers of people for a period of time, close together, breathing loudly, generally not masked. Go ahead. We go to, so I want to talk about kids for a minute because that's really important. We have a month till school starts. And one day last week, I actually saw 2 headlines right next to each other on my news feed. One said, children have much lower case numbers, and another one said, school children shown to be highly infectious. You're like, what? And because one study was looking at all ages of children, and their sample was predominantly teenagers. And one sample was a very careful scientific study by age and by pediatricians. And there is reasonable data that say that kids who are under 10, so when people talk about children, you have to really look by age. Kids who are under 10 are probably less infectious. The data is not great yet. So I would say that kids under 10 are probably less infectious, not definitely. The other thing is, all the time people say, oh, kids won't wear masks or can't wear masks. Actually, Kids are better about wearing masks than adults. I have yet to see a newspaper article about a child who took out a pistol or assaulted somebody when asked to wear a mask. Well, you can sort of like see those adult articles every day about adults. You know, I've been a teacher, I've been a camp counselor. You know, kids will do anything for a Jolly Rogers. So sometimes when people, you know, hear about this, you know, they look at what's happening in other states, and they look at some of the projections, and they feel like there's nothing we can do, and we're not helpless. Almost anybody can wear a mask, including the people who don't think they can, including kids. Remember, the protection's multiplied. You can make yourself and everybody around you safe. But also the risks add up. We need to avoid crowded situations. We need to avoid noisy en masse situations. I mean, noisy is interesting. There are some studies that have shown the level of background music in a bar correlates to the chance of a super spreader event. Because when the music is louder, everybody starts talking more. They also drink more, which is why the bar does that. So wear masks, close the bars, open the schools. Next. So I want to talk about vaccines because that was a question that came in the pre-screening thing. So let's talk about the what. The biology is interesting. The vaccine, which currently is the farthest along, are what's called a messenger RNA vaccine, which is essentially almost a synthetic virus. You're actually not given the vaccine itself. What you're given is a tiny injection of genetic material, RNA, that doesn't contain information to make a virus. It just contains the information to make the target protein, one specific target protein that doesn't cause any harm to the body, but the body will learn to react to. It of course is very efficient because your body makes most of the protein. It appears to be very, very safe because you're giving a small amount of messenger RNA to the body, but messenger RNA is something our bodies are full of already, which is a natural product. And the body then makes its version of the spike protein. Since it's new to the body, you develop an immune response to it. This is a very great idea, but this is a novel technology. This would be the first messenger RNA vaccine if it comes along. Another way of making a vaccine is something called a live virus vaccine, which is where you take a harmless virus. Adenoviruses are used for this commonly, and you genetically engineer that adenovirus, which is a harmless virus, to carry and express the spike protein germ. So this virus that is not dangerous to people will multiply in your body, deliver a bunch of the spike protein, which you'll become immune to. So you don't give the people coronavirus to become immune to it. You give them this non-dangerous virus. This is a technology we've used before for vaccines. It's a newer technology, but something that's out there. The classic way to make a vaccine is to actually take the protein from that you want the body to develop an immune reaction to, along with an adjuvant, which is a chemical that encourages the body to develop immunity. And like the hepatitis B vaccine, which is a very potent, well-studied vaccine, is done like this. You use a monoclonal, use a modified bacteria to produce large amounts of the spike protein, and then you give it with an adjuvant. That's a very classic, like 40-year-old technology. And so these are all being developed right now. Go ahead. What we're doing clinical trials right now to determine the efficacy and the side effects, how much of it, the dosing, whether or not you need 1 dose or 2 doses. Some of these vaccines will need 2 doses for a durable effect. A lot of vaccines do. We don't yet know that for these vaccines. A really, really important concept, and different vaccines have different effects, is whether or not the vaccine or even natural infection gives you mucosal protection. So mucosal protection means that when Art infects me, I breathe it in, I get the virus on my mucosa, and I kill it so fast, it never grows on my mucosa. It never grows in my throat, and I can't give it to Kate. Personal protection would mean that it would grow in my throat, in my nose. I wouldn't get sick. I would be asymptomatic, but conceivably I could still pass it on. Obviously, a vaccine that gives complete protection is better than one that only protects, because that prevents you from, that protects the whole community, not just you. And different vaccines are that way. So there are vaccines out there. It's interesting. We've been told that we are going to have a vaccine by the beginning of the year in actual production and distribution. I think that's possible. The Moderna, which is the first one listed up there, has had phase 1 and phase 2 studies published, and it is has started phase 3. That's one they're talking about having available for use at the end of this year. But what clinicaltrials.gov, which is where you register the trials, says that the people doing the study think that they're going to finish their studies in October of 2022, 2 years from now. Obviously, there's some hope that it could be done a lot faster. To be honest, the tremendous outbreaks in the South are making it easier to do the studies. But that's sort of interesting to me, the disconnect between what the researchers are saying and what the government is saying. A very different technology, the adenovirus, which is the AstraZeneca, which is out of England, which will also be worldwide distribution. They are predicting that they're going to have vaccine available for use next winter or spring, but their official publication date is supposed to be next summer, a year from now. And the Pfizer vaccine, which I don't think is actually part of the Operation Warp Speed officially. And according to verbal statements, not in writing, their study leader says that they think they're going to have results in either December or January. And they have also started their phase 3 trials. All of these vaccines are doing something which has historically never been done before, which is they are all starting bulk manufacture of the vaccines now, which takes months, on the hope that it works, so that we don't get the situation that in January we say, okay, Moderna works and Oxford AstraZeneca work, and we'll have it for you in 4 months. The idea is that they're going to make literally billions of dollars worth of vaccine in the next 4 months and hope it works, which would be great if it works, but it's not a promise. Some possible issues with the vaccines. The fastest a vaccine has ever been developed is 4 years. So we're not looking at trying to change the mile time from 4 minutes to 3:50. We're trying to run a 1 minute mile. Nonetheless, I think it's actually quite possible. We don't know if the response to the vaccine or the infection may wane. There is some early data that says that it's not going, that it appears to be durable. So far, there have been no cases, as far as anyone knows, of reinfection in people who had wild type infection. We discussed earlier about immunity being personal versus herd immunity. And then there's a interesting social issue. The first vaccine we give may be sort of effective. It may not be the best vaccine. How is society going to react if a year later we're like, okay, we want everyone to get vaccinated again? And then there's questions around who should get the vaccine first and whether or not it'll be required. I'm gonna real quick go through Birch Bay stuff, just so people are interested. We've done a lot of stuff to protect Birch Bay. We've got a lot of training for both the staff and the residents. Visiting is limited based on state and federal guidelines, and ability of the residents there go out on excursions under very specific guidelines and generally accompanied to make sure people stay safe. Next. We have worked very hard to get adequate PPE for our staff there, unlike a lot of, well, we're actually technically not a nursing home, we're an assisted living, but we have nursing home level PPE and better, and good training, and we have avoided any infections so far there. Go ahead. As far as testing, which I know is a question that has come up, we have tested our staff recurrently, which is both by state and federal guidelines. The only time residents should be tested is if there is evidence of either exposure or illness. We are exceeding the requirements as far as our testing of staff. And we actually had one staff member who was infectious on their initial screening, but PPE works due to the fact that they followed the rules on how to behave safely, even though they were infectious. They were found on screening, they weren't sick. They had infected none of their coworkers and none of the residents. So personal thoughts I use to guide me as I think about this stuff. Things are changing literally between when I started writing this talk 4 days ago and now. I had to revise some of the slides. We don't have all the answers now, but we have to act now. This was not an unforeseen or unforeseeable event. This has happened before in history, and it's going to happen again. The risk is real, but it can be reduced. Timeline, most likely we're going to have vaccines starting this winter with decent coverage by summer if we're lucky. And I'm suspecting we may have a decent antiviral drug available by winter as well. And final thought I want to leave people with, if we choose not to control the spread, we can expect 1 or 2 million Americans dead in the next 2 years, and it's a choice.
All right, so we do have some more questions that have come through. One of which was, with more cases in our community, is it still safe to go to the hospital?
Absolutely. We have, first of all, just to clarify, to get some clarification, that 35 case number, that is the number of folks that have called that report that they have received positive results from elsewhere, but that's through the entire season so far. And we had 5 last week, so that's the distinction. But the hospital, you know, as both Dr. Krevans and Kate have described, we do not currently and have not as of yet had any community transmission through our community. At our hospital, we take the position that our ultimate goal is the maximum safety, both for our staff and for our patients. So we have, as we would always have, very strict adherence to infection control guidelines, and there's a specific set of infection prevention guidelines that have been sorted through the medical community and the CDC. That our staff adhere to. We have done revisions to our building. We have revised our staff, our clinical schedules, all with a guide to assuring that people are adequately protected, both in terms of personal protective equipment, as well as appropriate social distancing. So I often joke that there's a perception that hospitals are kind of dangerous places, and maybe if we had a full hospital full of COVID patients, that might be the case. But I don't feel anywhere. I don't feel as safe anywhere as I do when I'm in this hospital.
Absolutely.
Absolutely.
Yeah, I agree too. Could you guys kind of more clearly define the terms isolate and quarantine?
Jared's really good at this one.
Okay,
We talk about it all the time.
so quarantine comes from now my sister, who might be listening and is gonna laugh because she's a classical scholar. Quarente, anyhow, it's an Italian word for 40 days because certain Italian cities during the plague would make ships anchor offshore for 40 days. Not if anyone on board was sick, but to see if anyone got sick. So quarantine is when you are suspected because of where you came from, or who you are, or who you've been near, but you're not sick. You are isolated, which is alone, and quarantine can be in a group. You are isolated, alone, when you are defined as truly infected. And interestingly enough, isolation can be shorter than quarantine, because once somebody gets sick, their body will clear the virus. But if somebody's been exposed, it sometimes takes a while for the virus to start growing. So it's sort of interesting. Sometimes isolation can be shorter.
Another one is, do any of the panelists have recommendations for facial coverings / protections if and when schools reopen?
I would recommend the wearing of a face shield, as JR did with his point of 6 and the numbers, looking at how much we have a risk reduction by being in close contact with each other. Asking kids to not be, to be greater than 6 feet from each other is going to be difficult. And so wearing a mask is going to protect them that much more. Kids are more accepting of masks than we are as adults. So certainly I would recommend wearing of masks when school opens.
Yeah, no question.
Yeah.
There are quite a few have come through. I don't think we're going to get to them all, but I'm trying to pick some ones that we haven't really covered yet. I haven't seen any specific recommendations for ventilation in publicly facing businesses. For example, keeping the doors and windows open in the post office or restaurants. Perhaps this should be made because you point out it helps protect us.
There is a state recommendation for that.
There is, okay.
There's definitely, and with the coming of winter, there's a bunch of stuff looking at UV irradiation, like high up in the room where the UV doesn't hit you, but it hits the recirculating air. Our engineer has already told me he's locked in a good price on oil for this winter because we're going to be exhausting more air from our hospital this winter.
Okay. Now here's a classic summer question. What about swimming? What are the risks? Indoor pool versus outdoors in a lake?
Clearly outdoor is safer than an indoor. Anytime you're going to be indoor and you're going to be in an aerosolized environment too, with the pool and the kids and the ventilation. So outside would be safer. Lake would be safer than a pool. The more spaced out, the more farther apart everybody is, their risk goes down.
Okay.
It's a good idea. Isn't it?
Yeah.
Hold on. Some of these are pretty. Is there a pull the plug plan if exposure here spreads?
Do you mean for the hospital? We have a 4-stage plan, of which we're in stage 2. And we have all and stage 4 has 3 stages in and of its own stuff. So we have a whole set of plans for what we do with increasing number of cases of different types that we revisit every week or 2 based upon supplies and science. The state also has its plan, but I don't know, but I know they track the numbers very closely, both ours numbers and other people's numbers.
Yeah, one of the things that I hope the public is hearing in all of this is that we are, as an organization, we are very committed to both our patient safety and our employee safety, as well as our community safety. And part of what we're trying to do today is provide support and education for the community to help keep our community safe. One of the ways that we are working to assure that happens is we literally have an incident command structure where some of the key members of the leadership that are involved in this effort literally meet daily. And we're reviewing current data, comparing notes with what other best practice organizations are doing, and really working very hard to make sure that we're providing services and support at a level that's commensurate with the science and with the environment of the community at that time.
And for people to understand that the things that could affect that are not just here. One of our limiting factors, which we've gone back and forth on in terms of what services we can provide, is what supplies we can get, which often has more to do with what's happening in Florida than it does here. Like as Kate mentioned, we'd love to be able to give everybody rapid tests. But we have last time I checked, we had 180 kits left. And I get a report periodically with exactly how many kits of each type are left.
All right, so I have two last questions that I think we have time for. Is it safe to have your teeth cleaned at the dentist right now?
We operate the Community Dental Center in Southwest Harbor, and so some of the modifications that we've made in that building is to increase the ventilation, and I think we've installed HEPA filters there. And plus, we, again, did not open the facility until we had enough. We had restructured some of the flow so that there was adequate distancing. The building airflows needed to be safe, as well as assuring, and with dental care in particular, which is really challenging, as JR mentioned, the level of PPE they use is significant. But again, it's critical that everyone that's involved in the process be appropriately protected.
And then lastly, are there any super spreaders, people and events in our area currently that you're aware of?
No.
And I answer all the phone calls that come through that are positive there or not.
Perfect. All right.
Okay, so thank you all so much for joining us today, and I want to especially thank our two speakers for giving the time and the attention to preparing for today. You know, as I said, we're very committed to the community safety, and one of the ways we're addressing that the safety in the community is through partnership with the Down East COVID-19 Task Force. In conjunction and in partnership again with the state, we're providing asymptomatic workforce testing to a cohort of front-facing tourism workers. The goal of this program is to detect any potential COVID-19 outbreaks as early as possible, which will allow us to not only protect those front-facing tourism employees, but also help reduce the threat of exposure for the entire community. And we are very pleased that so far we have had a 0 positivity rate in that program. Now, any future positives will be part of the reporting again in the total test results that we maintain on our website. So, okay. So, you know, it was interesting when Chrissy McGuire, our Chief Operating Officer, and I met with Dr. Shaw and Commissioner Lambrou yesterday. We had an interesting discussion because, as I said, they've helped to support this pilot along with the Jackson Laboratory and our hospital and a couple of very generous donors in our community. And so we were talking about the results of this program. We were talking about solutions to improve the contact tracing that goes on. But it was all within the context of that we are in the middle of a pandemic, and it is absolutely critical that we need to be continuously addressing safety and continuously addressing, understanding where this disease is in relation to our community and to the science. So COVID-19 is here. There are people in our community that are positive, and it's just important to remember that with adequate protections and with adequate protocols, we can continue to do the things that we need to do to protect our community. And we really, really strongly encourage all of our residents and visitors to remain hypervigilant in their precautions. So masking, physical distancing, and hand washing continue to be the best tools we have to spread this disease. And in this case, do as I say, not as I do. You need to have a mask that fits properly in order to do that. So thank you again for joining us today and for your commitment to the health of your neighbors and our community. And we will continue to keep you informed on the situation as things move forward. And we very much appreciate you tuning in today.